Imagine you have just spent, I don't know, a fortune restoring a vintage sports car.
Mhm.
You rebuilt the engine, replaced the alternator, tuned up the transmission. The mechanics under the hood are just completely
Right,
flawless.
it's totally sound.
Exactly. But then you finally take it out onto the highway and you realize the tires are completely bald. I mean, the engine is roaring, the systemic power is absolutely there, but there is just zero grip. You cannot actually feel the road.
Yeah, you're left with this really frustrating disconnect. You possess all the necessary baseline power to drive, but you lack the localized physical friction to actually translate that power into a thrilling ride.
Right. And today, for you listening, we are taking that exact concept of engine power versus road grip and applying it to a fascinating, highly debated frontier in women's sexual wellness.
Yep.
Welcome to the deep dive. We are looking at a really dense stack of clinical data, medical guidelines, and cosmetic literature to answer one highly targeted question.
Can a G-shot enhance arousal sensations in women who are already undergoing concurrent hormonal replacement therapy, or HRT?
So to unpack this intersection of treatments, we really have to navigate a diverse and honestly sometimes conflicting range of source materials.
We do. We're analyzing peer-reviewed journals and clinical guidelines from the American College of Obstetricians and Gynecologists, which focus heavily on systemic conditions like the genitourinary syndrome of menopause, or GSM.
Right.
But we're also looking at operational FAQs, pilot studies, and clinical data from specialized cosmetic gynecology clinics that are actually performing these aesthetic procedures on the front lines.
Yeah, so we're looking at the ultimate collision between systemic medicine, the HRT, and targeted aesthetic procedures, the G-shot. The mission here is to figure out, can combining a foundational hormonal fix with a localized physical amplification bridge the gap between baseline health and intense physical pleasure?
Well, to understand how those two interventions might synergize, we really have to start by looking at the systemic condition that necessitates HRT in the first place.
Makes sense.
The literature forces us to look closely at the pathophysiology of genitourinary syndrome of menopause. When hypoestrogenism sets in, so a drop in estrogen during menopause, the changes to the tissue are just profound and they cascade.
Yeah, the clinical journals describe GSM as a chronic progressive condition. The drop in systemic estrogen fundamentally alters the microenvironment down there. It's not just a subjective feeling of dryness. The lack of estrogen means the epithelial cells actually stop producing glycogen.
Exactly. And without glycogen, the local lactobacilli basically starve, the vaginal pH spikes, and you lose that protective acidic environment.
Which is a huge deal.
It is, because that shift in the microbiome triggers this massive cascade of inflammation and tissue degradation. The mucosa literally thins out.
Wow.
Yeah, and the collagen fibers lose their elasticity, and the vascularity, like the blood flow to the region, decreases significantly. This is exactly why up to 50% of postmenopausal women experience symptoms ranging from severe dryness and dyspareunia, which is painful sex, to recurrent urinary tract infections. The tissue's vitality is systemically depleted.
Okay, let's unpack this, because this is where the vintage car analogy becomes critical. For decades, the gold standard for treating this systemic depletion has been hormone replacement therapy, specifically local estrogen or DHEA therapies.
Right. The goal of HRT is to reverse that exact pathophysiological cascade we just discussed.
Yeah, it stimulates the epithelial cells to produce glycogen again, it drops the pH back to premenopausal levels, it increases blood flow, and it restores the structural integrity of the tissue.
So it's basically a chemical restoration of the environment. Localized HRT rebuilds the engine and the chassis, resolves the atrophy, and in doing so, it effectively eliminates the pain during intercourse that stems from that tissue degradation.
Right. But resolving pain is not the same thing as optimizing pleasure. Like, if HRT rebuilds the engine and ensures the car is mechanically sound, does it automatically give you the high grip tires needed to actually feel the road? Does it actually restore intense physical pleasure?
What's fascinating here is that the clinical data draws a very stark line between baseline restoration and sensory amplification. I mean, HRT is absolutely crucial for healing the tissue.
Of course.
But healing the tissue doesn't mechanically alter the anatomy to increase friction. HRT chemically restores the capacity for arousal, but it doesn't change the physical topography of the erogenous zones to make them easier to stimulate.
Which means the systemic power is there, but the localized friction might still be lacking. And that logic drives us directly into the mechanical intervention detailed in our cosmetic sources, which is the G-shot, also known in the clinical literature as G-spot amplification.
Right. And the procedure itself is remarkably brief. A physician uses a specially designed speculum to locate the Grafenberg spot and just injects a dermal filler, most commonly a highly cross-linked hyaluronic acid, directly into the submucosa.
Let's talk about the mechanics of that injection for a second, because the cosmetic literature is very specific about the biological goal here. The Grafenberg spot, or the clitorothoraginal complex, is a highly vascular erogenous zone. It's incredibly rich in nerve endings and erectile tissues.
Yeah, it's very sensitive.
So by injecting hyaluronic acid into this specific coordinate, the goal is entirely physical. The clinics describe augmenting the area to about the size of a quarter, or, a 5p coin. They are artificially creating a projection into the vaginal canal.
Exactly. They are manufacturing friction point. By increasing the volume in the surface area of the tissue, it naturally receives significantly more mechanical pressure during intercourse.
Right.
And from a neurological standpoint, increased mechanical pressure on those specific afferent nerve pathways translates directly into heightened arousal signals to the brain.
And the clinical data from the cosmetic sources boasts some pretty massive numbers regarding that specific mechanical goal. They cite a pilot study where 87% of women reported enhanced sexual arousal and gratification after receiving the procedure.
87% is high. But we do need to look at the pharmacology of hyaluronic acid in this specific application.
True.
Hyaluronic acid is hydrophilic, meaning it attracts and binds water molecules. When it's injected into the highly vascular mucosal tissue of the pelvic region, it behaves a bit differently than it does in, say, the dermal layers of the face. The body's natural hyaluronidase enzymes will eventually break it down and absorb it.
Yeah, and the clinics admit the effects aren't permanent. Our sources indicate the amplification lasts anywhere from 4 to 12 months before the body fully metabolizes the filler. But I have to challenge the premise here. A 4 to 12-month window means a patient is looking at returning for injections 2 to 3 times a year. Aren't we subjecting patients to a highly sensitive, invasive injection schedule that sounds less like a localized cure and more like a subscription model for sexual health? Like, is this a magic bullet for anyone struggling with intimacy?
Well, that is a major point of contention in the literature. The cosmetic clinics argue that facial fillers operate on the exact same maintenance schedule, and patients willingly accept that temporary augmentation for aesthetic reasons. They basically frame the G-shot as a similar lifestyle enhancement.
But the stakes are vastly different, right? Plumping a lip is not the same as injecting filler into an internal network of highly sensitive autonomic nerves. I compare it to installing a bigger volume knob on a stereo. Does it matter how big the knob is if the stereo isn't even plugged in?
That's a great way to put it. You can install the most aggressive high-grip tires in the car, but if the engine is completely dead, the car still isn't going anywhere.
Exactly.
If a woman is suffering from severe menopausal dryness, or her libido is completely suppressed by a systemic hormonal crash, injecting filler to make a spot the size of a quarter isn't going to suddenly generate arousal.
And the specialized cosmetic clinics are surprisingly transparent about this limitation. Their own operational FAQs explicitly state that the G-shot is not a treatment for emotional, psychological, or systemic libido-based sexual dysfunction. It is strictly a mechanical amplifier.
Right. If the tissue is thinned out and painful due to GSM, localized friction will not restore natural lubrication or heal the epithelial lining. In fact, adding mechanical pressure to atrophic tissue could theoretically just exacerbate discomfort.
Here's where it gets really interesting, and this loops perfectly back to the core mission for you listening today. If the G-shot is useless for hormonal dryness, and HRT doesn't physically alter the anatomy for increased friction, what happens when they are strategically paired?
Yeah, what happens when you combine the systemic chemical restoration with the localized mechanical amplification?
Exactly, because lack of sensitivity is often a product of hormonal imbalances, and the sources explicitly state that a G-shot will not solve hormonal issues.
This really represents a shift toward a multidisciplinary approach to female sexual wellness. One of the clinical sources makes a very poignant observation regarding severe vaginal atrophy. They state, quote, "A patient using only one tool for a condition that's systemic will get partial relief. The right combination, dosed and timed correctly, can restore quality of life."
So concurrent use acts as this highly strategic, two-pronged protocol. Prong one is the HRT. The hormone therapy restores the estrogen levels. It forces the tissue to rebuild the glycogen, dropping the pH, thickening the vaginal walls, and restoring the baseline elasticity and blood flow.
The engine is completely rebuilt and primed.
Yeah, once the stereo is plugged back in, prong two is introduced. The G-shot mechanically alters the physical topography. It creates that targeted volume to maximize the friction.
And because the surrounding tissue is now healthy, well lubricated, and highly vascular due to the HRT, it is fully capable of processing the increased mechanical pressure into intense arousal sensations without pain or tissue tearing.
It's like putting a magnifying glass over a newly repaired map.
Yeah.
Each RT restores the map, but the G-shot zooms in on the destination. It is the perfect synergy. The anecdotal evidence from these cosmetic clinics suggests it is a profoundly effective combination for women seeking a complete restoration of their sexual vitality.
The logic of the synergy is biochemically and anatomically sound, for sure. However, viewing this combination therapy as a flawless, risk-free cure-all ignores the stark reality of the broader medical consensus. We are still discussing elective, off-label medical procedures in a highly complex anatomical region.
Right. I mean, it sounds perfect, but we have to look at the actual medical reality. What are the actual risks of injecting fillers into such a sensitive area? An area packed with vascular plexuses and nerve clusters. It cannot be without serious downsides.
This raises an important question regarding patient safety and medical ethics. To understand the gravity of these procedures, we have to look at the American College of Obstetricians and Gynecologists, or ACOG. Specifically, we must examine their Committee Opinion number 795, which explicitly covers elective female genital cosmetic surgery.
And ACOG is unequivocally aggressive in this document. They're certainly not endorsing those cosmetic clinic pilot studies.
Not at all. Their primary warning hinges on the burden of proof. ACOG states that there is a severe lack of high-quality, long-term, peer-reviewed data supporting the effectiveness and safety of cosmetic genital procedures.
Right.
The 87% success rate cited by the cosmetic clinics often comes from small, industry-funded pilot studies without double-blind, placebo-controlled parameters.
And ACOG also takes major issue with the terminology used in direct-to-consumer marketing. They specifically call out the word rejuvenation. Claiming a dermal filler rejuvenates the tissue implies it is returning the body to a natural, biologically youthful state.
Right, which it isn't.
Exactly. Injecting hyaluronic acid to artificially create a quarter-size projection is an anatomical alteration. It is an augmentation, not a biological rejuvenation.
And ACOG stresses that characterizing normal anatomic variation as something that necessitates medical intervention exposes healthy women to unnecessary surgical risks. And the complications associated with pelvic injections are incredibly specific and, honestly, severe.
Yeah, the sources outline risks that go far beyond a typical allergic reaction. We are looking at potential urinary retention, where the proximity of the filler to the urethra physically obstructs a patient's ability to empty their bladder.
Wow.
Yeah. There is the risk of fistula formation, creating abnormal connections between the vaginal wall and the urinary tract. There's the risk of fibrosis and scarring within the submucosa, which could permanently damage the nerve endings and lead to severe chronic dyspareunia. I mean, you could go in trying to enhance pleasure and end up permanently destroying your capacity to feel it.
That's terrifying. But the most severe physiological risk highlighted across the dermatologic and gynecologic sources is intravascular injection. The pelvic region contains a dense, intricate network of anastomotic blood vessels.
Right.
If a clinician accidentally injects the hyaluronic acid directly into one of those vessels rather than the surrounding connective tissue, the filler can travel.
Which can lead to a non-thrombotic pulmonary embolism. The filler essentially acts as a localized clot that travels to the lungs. That is a fatal complication. You were talking about a patient walking into an outpatient clinic for a 10-second lifestyle enhancement procedure and ending up with a pulmonary embolism.
Exactly. And the regulatory context here is vital to understand. The hyaluronic acid utilized in these procedures is FDA approved, yes, but it is FDA approved for facial dermal filling.
Right.
The collagen injections sometimes used are FDA approved for intrinsic sphincter deficiency to treat incontinence.
But utilizing those materials for G-spot amplification to enhance sexual arousal is completely off-label.
It is. Now, off-label prescribing is a foundational legal practice in modern medicine. Physicians frequently use well-tested approved drugs for purposes outside their original patents.
Of course.
But ACOG's strict position is that the safety profile of this specific off-label use injecting temporary fillers into the highly vascular clitorovaginal complex has simply not been validated by the rigorous, non-industry-funded clinical trials required to declare it broadly safe.
So what does this all mean for the patient? We're looking at a massive, almost irreconcilable gap between two different medical worlds. In one arena, you have the specialized cosmetic gynecology clinics operating on the cutting edge of aesthetic demand.
Right.
They have thousands of patients, glowing clinical testimonials, an 87% pilot study success rate, and compelling biological logic supporting their multidisciplinary approach. They view the G-shot, especially when paired with HRT, as a highly effective, low-risk tool for reclaiming sexual empowerment.
And in the other arena, you have the traditional evidence-based medical establishment, represented by bodies like ACOG. They are prioritizing the foundational oath to, first do no harm. They are demanding rigorous scientific validation to protect patients from the rapidly expanding, highly lucrative world of direct-to-consumer medical marketing.
It puts you, the patient, right in the middle of a complex medical tug-of-war. You have to synthesize the theoretical benefits against the unquantified long-term risks.
Yeah, but if we synthesize the data to directly answer the core mission of this deep dive, yes, theoretically, and according to the physiological mechanisms we've explored, a G-shot can highly enhance arousal sensations for women who are on concurrent HRT.
Right.
The pathophysiology supports the synergy. HRT chemically heals the systemic hormonal deficits, rebuilding the tissue and restoring the biological capacity for pleasure. The G-shot then mechanically alters the anatomy to provide the localized physical friction required to maximize that restored capacity.
You rebuild the engine so it has the power to run, and then you put the high-grip tires on the wheels so you can actually feel the road.
That is the mechanical reality. But patients really must navigate this space with a clear-eyed understanding that they are bridging cutting-edge, off-label aesthetic practice and traditional evidence-based caution.
For you listening, whether you are actively exploring options for your own sexual wellness or you're just deeply fascinated by the evolving intersection of endocrinology, anatomy, and medical regulation, this topic reveals a massive societal shift. It proves that women's sexual health is definitively stepping out of the shadows.
Yeah, absolutely.
For generations, conditions like the genitourinary syndrome of menopause were dismissed as just a natural, unavoidable consequence of aging. Women were expected to simply tolerate the pain and the systemic depletion of their vitality.
And if we connect this to the bigger picture, the very existence and the explosive popularity of these concurrent treatments demonstrate that patients are actively rejecting that passive acceptance. The demand for both systemic hormonal restoration and localized aesthetic enhancement shows a patient population actively seeking multidisciplinary interventions to reclaim total ownership of their physical well-being.
It is a profound shift toward active empowerment in sexual health. But as we wrap up this deep dive, I want to leave you with one final lingering concept that none of the clinical guidelines, cosmetic brochures, or pilot studies we reviewed today can fully quantify.
What's that?
We've talked extensively about the physical mechanisms. We know that HRT chemically restores the tissue's baseline environment. We know that procedures like the G-shot mechanically alter the local anatomy to increase physical friction. We have isolated the chemical and the mechanical. But how much of the resulting gratification is actually being driven by the brain?
Oh, wow. Yeah.
Right. Consider the profound psychological weight of taking active control over a condition that you were told you just had to live with. If a patient proactively researches specialists, balances their systemic hormones to eliminate chronic pain, and invests in an anatomical procedure specifically designed to prioritize their own physical pleasure, how powerful is that psychological shift?
It's massive.
Could the sudden elimination of physiological anxiety, combined with the sheer undeniable expectation of enhanced pleasure after taking control of one's sexual health, trigger a cascade of neuroplasticity that eclipses the filler itself? Could that psychological empowerment be the ultimate yet untapped erogenous zone?
That is a fascinating way to look at it.
We spend so much time analyzing the chemical environment and the mechanical friction, but perhaps the ultimate, most potent erogenous zone is simply the psychological empowerment of finally taking the wheel. Something for you to think about.